Our first speaker this morning is Kathleen Pontillo, who's a professor of nursing from UCSF with a long-standing interest in assessment and management of symptoms in the ICU. So she's going to talk to us today about something that I think we don't think about enough in the ICU, and that's relieving thirst. Thank you.
Thank you very much. Good morning. I'd like to thank the organizing committee for inviting me to present this study, and I also want to mention that I have nothing to disclose. So this is a study of thirst in ICU patients. And a few important points. Excuse me. Thirst is actually one of the most pervasive, intense, and unrecognized symptoms in ICU patients. And certainly if it's not recognized, it hasn't been treated effectively. Now, there are many biological and clinical and treatment-related factors that can influence thirst, but I think it's important to note that treating thirst and doing patient mouth care are not the same thing. I'm sorry. Mouth care does not necessarily effectively relieve thirst. When we think and look at the literature in relationship to thirst, have been many surveys of patients after their transfer from the ICU, and on those surveys, thirst has been identified as one of the most stressful experiences for patients. We really haven't looked at thirst in a prospective manner until very recently. So this was a study, a single-blinded randomized clinical trial in 3 adult ICUs at UCSF Medical Center in the cardiovascular, medical, surgical, and the neurointensive care units. And the hypothesis for the study was that thirst intensity and thirst distress will decrease significantly over time in ICU patients who receive a thirst intervention bundle compared to those who receive usual care in the ICU. And this was a study that was funded by the NIH. We included patients who were 18 years of age or older. They had been in the ICU greater than 24 hours, spoke English, were oriented to their name, to where they were and their birthplace, and they were neither sedated or agitated. And they had either a thirst intensity or a thirst distress score of 3 or greater on a 0 to 10 numerical rating scale. In looking at the patient flow diagram, you will see that there were 950 patients who had eligible thirst scores at 3 or greater on intensity or distress. We were not able to enroll 698 of them for various reasons: cognitive impairment, they were too tired, they were in pain, other limitations, but many of them declined to tell us why they were not interested. So we were able to consent and randomize 252, 129 to the intervention group, and 123 to the usual care group. Let me tell you about our research-based thirst bundle. The bundle was developed as a result of prior experimental research, or certainly non-ICU research, and the whole bundle had never been tested. But the bundle consisted of the use of cold versus warmer water, because cold water has been identified to give greater thirst relief than regular room temperature water. We also used cold water sprays to the oropharynx and the tongue area. We swabbed the patient's mouths, and then at the end of the first intervention, we applied mentholated moisturizer to the lips. Now, mentholated moisturizer, the menthol is theorized to stimulate cold receptors in the back of the throat. Now, it wasn't necessary for patients to swallow the cold water, because there is evidence that just having cold water at the back of the throat, where the oropharyngeal receptors are located, causes a thirst satiety. You don't have to swallow it in order to get the thirst relief. That was the theory upon which the bundle was based. We had 2 groups, and in the intervention group, research team nurse number 1 took the pre-intervention thirst scores, thirst intensity and thirst distress, delivered the thirst bundle, which was a series of cold, sterile water swabs, the sprays to the back of the throat, did that 2 times within a 15-minute period, and then applied the methylated moisturizer. And then that nurse left and called the second nurse, who was blinded to the intervention, which group the patient was in, and that second nurse obtained the post-intervention thirst intensity and distress scores. So this was a single-blinded study. The usual care group, we did not interfere with any of the normal care that a patient would have during this time period. Our nurse, the research team nurse, observed what was going on in the room and took notes. But we didn't interfere with any usual practice. And then the second nurse came in, again blinded, and did the post-intensity, thirst intensity and thirst distress evaluations. We repeated this intervention twice on day 1, with a minimum of 30 minutes between the interventions, and actually the average time between the interventions was something like 40 to 50 minutes. And then if patients were still in the intensive care unit and still able to participate, we repeated 3 sessions on day 2. And the observation time, a similar amount of time, was done to the usual care group, both on days 1 and day 2. We use multiple regression analysis with random intercepts to determine whether the decrease in thirst intensity and thirst distress over time was greater in the intervention group. We had 3 within subjects factors. The first was the before and after scores at each session, the pre and post scores. We had 3 sessions per day, and we had 2 days. And what we found was it didn't matter how many sessions a patient had or how many days the patient was involved in the study. Those were not significant factors. That indeed, what we found was, well, let me tell you a little about our sample. The demographics are very, very similar. There was only one significantly different factor, and it's the last one on this slide, the number of sessions completed. There was, in the usual care group, they completed an average of a half of a session more than the intervention group. Remember, we could have had 6 sessions, but again, there was attrition, primarily due to transfer of the patients from the unit. So as I said, the average difference due to days and sessions were not significant, but looking at the average change scores from pre-session to post-session, the individual session, without regard to session number or day, we did find a significant decrease in thirst intensity and distress, being greater in the intervention group than in the usual care group. So just to provide some perspective on what these scores, how these scores moved during the intervention or observation period, you will see in the no intervention group, the pre-thirst scores were 5.3, post-thirst were 4.7. In the intervention group, pre-scores were 5.9, post were 3.6. And to provide some context to that or some more information, the usual care group scores decreased only by 0.7, and the intervention group decreased by 2.3 scores. Now, to provide even more context to that, extrapolating from pain research studies, because there is no such study in relationship to thirst, any change that is 1.7 on this type of a scale is considered to be clinically significant. So this was a clinically significant, if we can extrapolate from pain research, this was a clinically significant decrease. And this is just a visual representation of the decrease in thirst intensity, with the intervention group being in green and the usual care being in the dotted blue. In relationship to thirst distress, again, there was a significant decrease. The scores only changed by 0.4 in the no intervention group and by 1.8 in the intervention group. Again, a statistically significant and a clinically significant score. And it might not sound like a very big difference in score, but again, if we look at pain scores and the research that's been done on that, these patients' thirst intensity and distress scores changed from a moderate degree to a mild degree of thirst. Again, a visual representation of the decrease in thirst distress over time, with the green being the intervention group. There are a number of limitations to the study that I'd like to acknowledge. We did have a high refusal rate. We are doing prospective research in ICU patients where they needed to participate and needed to be clear enough to be able to provide valid numeric rating scale scores. Unfortunately, we had a small number of patients who were mechanically ventilated, only 15 in the study. It was this tension between when they were cognizant enough to be able to participate before they were transferred from the intensive care unit. Some patients in the study did receive small amount of fluids during the trial period, but interestingly, people in the usual care group received more fluids than in the intervention group, and more people in the intervention group were NPO. The other limitation is that this was a bundle, and the effects of the individual parts of the bundle were not analyzed. However, individual parts of the bundle had been researched before. And another limitation was that we do not know the exact duration of the effectiveness of the intervention because we allowed for 30 minutes or at least 30 minutes to lapse between the post-intervention assessment of their thirst and the next session. So we don't know how long it lasted. But in conclusion, I'd like to say that it's a simple, easy to apply bundle for thirst relief in many patients who have a thirst in the intensive care unit. And its intensity and distress both decreased and should be considered as a possible intervention for the many patients in ICU who experience thirst. Thank you.
So I guess we can have a few questions and then we have some editorial comment. Any questions out there? And there's a microphone in the middle. Maybe I can ask you a question. So did you look at, or was there any relationship with delirium or agitation? I recently, in fact, last weekend had a patient in the ICU who was quite agitated, and then the nurse eventually gave him a large meal and everything settled down. And it made me wonder whether some of what we see was hunger or thirst.
That's interesting. We did not do a CAM ICU or another method of assessing their delirium, but we did do specific questioning of them to get to their level of alertness and orientation. We asked them some questions after we had gone through the informed consent process about will you get paid, yes or no, because that's part of the informed consent process. What do you do if you want to withdraw from the study? So we asked some specific cognitive assessment questions. But I think you're right. I took care of a patient one time who just kept pointing to something like this, and I felt sure she was delirious. I couldn't understand what she wanted or what she was doing. And then I turned to where she was pointing, and she was pointing to the cup of water with the swab in it.
Okay, some questions.
I have a question too. Do you have any objective measurement? Did you try to correlate the intensity or the distress, the baseline intensity of thirst with some surrogate of osmolarity as a sodium concentration, urine output, electrolytes concentration, et cetera,
Yes, actually we did. We looked at a lot of chemistries, sodium, potassium, osmolality, and so forth, and there were no significant differences between groups. We also looked at, at certain medications that are proposed to cause thirst, such as opioids, Lasix, a few other medications. There was no significant difference in the amount or frequency.
I'm not wondering between the two groups. As a baseline, you have a scale that tells I'm in 1, 2, 3, 4, or 10. These numbers, so the severity of this number, is somewhat related with biochemistry or not?
Well, we did. There was a second aim to the study, which I'm not reporting today, and we're looking at predictors of thirst. And we have looked using regression models at factors that both could predict whether the patients were thirsty or not thirsty, because we had a third group of not thirsty patients, as well as predictors of the intensity of thirst and the distress of thirst. So those analyses are ongoing.
Okay, thanks.
Thank you, Dr. Pontillo, for an excellent study. As I'm trying to drink it all in, I'm just wondering why you chose not to do the study also on intubated patients or patients who are maybe not as able to express their needs. I mean, I would probably be less concerned about the person who's awake, alert, oriented, and able to talk to me and tell me, I'm thirsty, please give me something to drink. Then I also wonder, like Dr. Lipinski's question, how often we have these extremely challenging to manage delirious intubated patients. We have no idea what's wrong. How many of those times is it simply that the person's thirsty or they've got an itchy nose and they're not actually delirious and we're, putting them into the Stone Age with quetiapine?
Yes. The second part of your question was, how do we identify if a person is delirious or agitated and not able to report? I think in some respects we should assume that this thirst possibly exists, because I went through very rapidly the prior research, but in a prior research study of mine, thirst was the most prevalent study. 71% of patients reported thirst, and this was from over 400 surveys, and it was the most intense symptom of the 10 symptoms that we evaluated. So there could be some degree, with lack of evidence, to assume and to ask if the patient is thirsty, if the patient is cognitively able to respond. If not, I would propose that a thirst intervention be done. We, too, were very disappointed. We didn't have more mechanically ventilated patients in the study. We did not choose to exclude them. They were excluded because of their cognitive status, their ability to self-report, and not just shake their head yes or no, but they had to give us scores. So, the disappointment comes from the fact that it is highly likely that patients who are mechanically ventilated with their mouths open will be experiencing thirst. They just weren't able to report the numbers to us.
I just wondered, in one study I've seen where they put people into water up to their neck, there's a significant relief of thirst in that population compared to those that aren't. And I'm wondering whether whole-body TEDs or something equivalent might be possible to improve thirst. And is there any comment?
Whole body?
Like a tight-fitting stocking to shift fluid from the interstitial space back into the central blood volume.
That's a very intriguing thought, and I have no response to it. I don't know. I've never seen anything in the critical care or other literature that I examined.
Okay, so we have an editorial comment, and the program has changed. Dr. Azalea.
Thank you. So thank you. So I'm very, very proud to provide an editorial comment on this very nice study for which, Kathleen, you taught us that nursing research is part of the critical care research overall, with high quality and most of the time very relevant findings. So if I may, I just want to first thank you for the invitation and for this opportunity to provide a comment. And just to remind to the audience that we are dealing with a symptom that has a very strong background. And we are now in a period where after having the time for observation, seeing that in 60 to 70% of the ICU patients that have been surveyed for their symptoms in the ICU, we are not anymore in the time where we are collecting information about the symptoms, we are now intervening. So Kathleen Pontillo and the co-authors should be very much complimented for that. We are in a time where we are stopping observing the distress of people. We are trying to improve the ICU experience on a symptom that is very frequent. So the relevance of the intervention relies on a very, very sound background. We are also where first can be considered as one frequent symptom, but also one symptom that has a very bad impact on the ICU experience. So it is frequent, and decreasing this symptom is relevant because we could say that the intervention that has just been presented has an immediate outcome, that is the decrease in pain, in thirst intensity and thirst distress. But we could also consider that surveying the ICU survivors after ICU discharge, maybe 1 week or 10 days or 1 month after discharge, we could also collect information on how useful was the intervention for decreasing the post-ICU syndrome. When we are looking at an RCT, we need to consider that we are with a very important thing on which we are intervening, but also a very important outcome. So how much first can be considered as an outcome, how much reliable is the intervention, and are we sure that we are with an outcome that is going to be part now of what we should collect in the ICU? And when we are looking first at this study, we say, wow, this is something I never provided interest to this. I never asked my patients if they were thirsty or not. When I'm thirsty, I'm drinking. When I'm painful, I'm taking pills to decrease my pain. But I've never did that for my patients. So now on a technical standpoint, I'm going to provide Kathleen with some opportunities to provide us more information about the rationale for the sample size, something that needs to be explained. As in this study, we have 2 primary endpoints, and this may be something on which we need to discuss. The randomization scheme, the allocation concealment, the bleeding. It was a single-blinded, of course, and you explained very well why there were 1 in nurse for the pre-intervention and 1 for the post-intervention. Not everyone can be blind of this, but we need to address this technically. We need to have information on the dropout, and we need to consider the JADED score. The JADED score is a way to score a randomized control trial, and we have enough information on the process of randomization, on the blinding, and on the withdrawals, and then we can consider that the study is eligible for being considered in a major journal, and I consider that this study is a major one. When we are looking at the epidemiology of published randomized control trial, we know that the ability of investigators to provide all information on the consort guidelines is fine in only 50% of the cases. Going to this study, we can see that we will have some more information on the power calculation. We have 2 co-primary outcomes, and this is fine as the 2 primary outcomes are very much connected. I don't think that we can consider that third intensity and third distress are completely independent. Then they can be considered as co-primary endpoint. We have the information on the blinding. We are going to have the random sequence generation. We have information on the allocation concealment, and we have also the information on the dropouts. So now, if we are taking back the study to our ICUs and to our clinical practice on a daily basis, we need to be aware, more than people like you who have fought on the study since years, how can we have a take-home message that is very easy to get? And what's the difference between thirst intensity and thirst distress. And I maybe suggest that the nurses and the research nurses should maybe create a tongue score to help clinicians understand if the patients are thirsty. And we are back to the question that has just been addressed about patients receiving mechanical ventilation not being able to provide information on their intensity. And we should find surrogate markers of thirst, as we are now completely convinced that this is of utmost importance. Also, there are some confounding factors. You have provided information on fluids, but also diuretics. We note, for example, that also patients with cardiac failure may express thirst. But this slide is certainly showing that these outcome measures are not very much validated. It's not something. Pain distress, pain intensity, thirst distress, thirst intensity is very much in the literature, and we can consider that we have a very reliable outcome and that the intervention was successful in decreasing immediate outcomes using this score, and we need to go back to further outcomes and to short-term outcomes. And I would say that this study should open a new field of research on the long-term outcome of these symptoms and, of course, of these interventions. So just to go back on the confounding factors, I think that heart failure are one. Luciano Gattinoni have addressed the question of the baseline level of thirst, but also all the surrogate markers of thirst. It could be osmolality, it could be sodium in the urines, it could be many things. I think also that some patients are with water restriction, cirrhosis, and the third sector, fever, and many are on dialysis, of course. And I think that this should be addressed, and maybe the research should be also provided based on some adjustments on these confounding factors, but the intervention provides so huge effect that I'm sure that I'm confident that it will be still very relevant. Kathleen, again, thank you, and we are very proud to know you. Thank you.
Thank you, Ellie, for your wonderful, thoughtful, brilliant thoughts about evaluating randomized clinical trials in ICU patients. I will take a few minutes that are left to respond to some of your comments. As far as randomization is concerned, well, we talked about randomization. We did do an a priori power analysis to determine the estimated sample size that we would need using an effect size of 0.35, an alpha of 0.05, power of 0.80, and allowing for loss of patients for various reasons in the ICU over time. And we calculated that we needed 101 patients in each of the groups and 69 to remain in the study, and we had fewer than 69 remaining in the study. Obviously, in spite of that, we reached statistical significance in relationship, so our power analysis was done before the study. As far as the withdrawal of patients, there were some patients who withdrew from the study for various reasons, and sometimes it was, I didn't consider a person to have been withdrawn from the study if they did not meet all the 6 times. They were in the study until they left their unit or something like that. But in the process of the study, there were about 28 patients who withdrew from the study for various reasons. I found your comment about doing an objective tongue analysis or evaluation very interesting. Indeed, we did do that. We added some objective measures looking at doing an evaluation of just that, the tongue. It's amazing what you find out, how much you can evaluate of a tongue. It was the color, the crevices, and so on and so forth. So we didn't start it right at the beginning of our study, but we did include that after a period of time. The other comments that you considered as far as either confounding or causative or predictive of thirst. We are looking at many of those, including hydration status, the chemistries, the drugs, and many, many other predictors, and a future analysis will be done to report those findings. Thank you.
Okay, well, thank you very much to both our speakers. We need to move on to our next session to keep the day on time. I see Neil Ferguson anxiously wanting to start. Okay, thank you very much.
The problem is that